Thank you very much. Anyone who knows me knows that I'm crazy about EKGs. I've collected them and taught EKG-related topics for 25 years. So today I want to spend a few moments talking about an often neglected and a much maligned lead AVR. I have no financial disclosures, but I do have a free open access website with all kinds of EKG material if anyone's interested. So lead AVR, this is where it's located, and I bet the majority of us quickly interpreting EKGs don't pay much attention. If we look at it up close, notice that all of the complexes, P, Q, R, S, and T, are inverted. This is because of the axis with the positive lead on the right shoulder. This is how it should look. And when it doesn't, interesting things conspire. These are the things that I think lead AVR can help us with. Switched arm leads, just setting it up wrong, Dextrocardia, critical left main coronary occlusion and other ACS presentations, pericarditis, tricyclic antidepressant toxicity, and sometimes the mechanism of SVT. There are others where AVR is more an added piece to the diagnosis of pulmonary embolism, aortic dissection. Verecki from Hungary has actually made an algorithm to discern VTAC versus SVT based only on AVR. So these are things to consider. This first ECG might pass through an attending signature without quick notice, but do notice that AVR is all upright, the P, the Q, R, S, and the T wave. This is wrong, it just doesn't figure. In addition, if you look at lead 1, you now see this large negative component giving us a right axis deviation. This is the sign of switched arm leads, right and left, and you need to politely ask the EKG tech if they would go back, do another, and perhaps double check the limb leads. Very similar in appearance is the EKG from a patient with dextrocardia. Now, instead of swapping the limb leads, we've actually moved the heart into the right side of the chest. And so again, we get that upright complexes in AVR and the negative in 1. But what distinguishes this from just swapped arm leads is look at the chest leads. They make no sense. There's no progression of the R wave. They're small. And this is, in fact, because they're on the left chest while the heart is on the right. With correction of the chest leads, you now have an interpretable, useful ECG. Tricyclic toxicity, most of us appreciate that changes occur, including development of an R wave in AVR. Other signs of toxicity include widening of the QRS, widening of the QT interval, and tachycardia. The EKG findings of tricyclic antidepressant toxicity precede the cardiac and the neurologic symptoms. And Liebelt published an article in our literature years ago where he found that an R wave in AVR, 3 or more millimeters, was the only finding that predicted toxicity from tricyclic antidepressant toxicity. It only had a sensitivity of 81% and a positive predictive value of 43%, but when you're looking at someone with a possible toxic ingestion, it's a very useful sign. If you increase the R in AVR to, say, 5 millimeters, as in the case I showed you, you get a specificity of 93%, but you're not going to see that too often. Critical left main coronary artery occlusion is thankfully a rare occurrence, and it's a dramatic presentation. In this EKG, you see dramatic ST segment depression in multiple leads, in fact, in 8 of the 12 leads. And you also see ST segment elevation in AVR. This dramatic presentation was first reported by Hans Wellens a number of years ago, and he felt it was very predictive of critical left main occlusion, which is worthy of being identified because you've got to get these patients to cath to have that critical obstruction identified, and the majority of them then go to emergency bypass surgery, as the lesion is not really amenable to plasty and stenting. AVR ST elevation also occurs in the other less dramatic ACS presentations. It can occur with some left anterior descending lesions, with diffuse three-vessel coronary disease, and sometimes, even in patients without a diagnosed infarct, it can predict an adverse outcome at 90 days. Pericarditis can be tough. It's subtle ST elevation. There's all kinds of things we look for to discern if it's ACS or pericarditis. One thing that is useful, I find, is PR segment deviation. In this case, look at AVR. If you make a baseline, there's actually PR segment elevation. Similarly, in lead 2, PR segment depression. This comes about from Spodek's sign in pericarditis fame. He followed EKGs and found that PR segment deviation occurred frequently. In fact, he thought PR segment elevation in AVR was ubiquitous. And finally, I'll show you that reentrant tachycardias, SVT, of either nodal or bypass tract type the mechanism can be discerned by looking at AVR in many cases. This slight ST elevation in AVR predicts a bypass tract SVT. You don't change management because of that, but you get some ooze when you end up with WPW once your conversion is done. Ho noticed this while doing EP studies. It has a 70% sensitivity and specificity. It's not management related, but it is a crowd pleaser and fun to note. And so I end by saying, respect the power of the AVR. You can determine dextrocardia or limb lead switching. It can help with ACS presentations, toxic ingestions, pericarditis, and occasionally help you discern the mechanism of SVT. Thank you.